So we are discussing on history taking and clinical examination in a patient of chronic liver disease. So for what complaint the patient might present to us in a chronic liver disease case, it is usually the distension of the abdomen. It is usually the distension of abdomen for a particular duration. It is the distension is not sudden, but it is a gradual and progressive distension of the abdomen, which we will discuss later in history of present illness. But the chief complaint is usually the distension of the abdomen or swelling of the bilateral lower limb. The swelling of bilateral lower limbs. So, based on our chief complaint, we have to keep our mind open in a sense that we have to think of many possible diagnoses or as much as possible diagnoses we can based on our chief complaint. So, if the patient is presenting to us with distension of abdomen, we have to first think that what can cause this abdominal distension. So, there are 5 Fs which can cause this abdominal distension. What are these 5 Fs which can cause abdominal distension? This can be fluid inside the abdomen or the ascites which can cause abdominal distension. It can be simple fats. It can be simple fats which can cause abdominal distension. It can be flatus or gas which can cause gaseous distension of the abdomen. It can be fetus. It can be fetus in a female patient which can cause abdominal distension. Sometimes the full bladder. The full bladder can also cause abdominal distension, and sometimes in a patient of intestinal obstruction, the feces can cause abdominal distension. So if the patient is presenting to us with distension of the abdomen, we have to keep our mind open in a sense to identify what are the possible cause of distension of abdomen. We should not come or we should not conclude a diagnosis based on only distension of abdomen that this distension is probably because of ascites, because of portal hypertension in a patient of chronic liver disease. But at first, while elaborating the chief complaint, we have to keep our mind open to go in a line of diagnosis. So what are the basic 3 rules of history taking is that first we have to elaborate our chief complaint. So we have written our chief complaint that the chief complaint of the patient is distension of the abdomen and swelling of the bilateral lower limb. So let's suppose the distension of the abdomen is for around 6 month duration and swelling of the bilateral lower limbs is for around 4 months duration. So it is important to mention the history or it is important to mention the chief complaint in a chronological order, which means that event which occurred first should be mentioned first. In our case, it is the distension of the abdomen which occurred first, which occurred 6 months, which is occurring for 6 months is mentioned first, and the swelling of the bilateral lower limb which has occurred later for only 4 month duration is written as second chief complaint. So the basic 3 rules of history taking is that first we have to elaborate our chief complaint in order to go in a line of diagnosis. So first we have to elaborate this chief complaint in order to go in a line of diagnosis. Second, we have to take some negative history to rule out other differential diagnoses. So first we have to elaborate our chief complaint in order to go in a line of diagnosis. How we have to elaborate the chief complaint? Let's suppose the patient is presenting with distension of abdomen. So distension of abdomen can be either because of fluid, fats, flatus, feces, full bladder or feces. So we have to elaborate our chief complaint in a such a way that we are going in a line of diagnosis of chronic liver disease that this distension is probably because of fluid, not because of flatus, feces, fetus or full bladder. So that is elaborating the chief complaint in order to go in a line of diagnosis. We will discuss this later. The second important aspects of elaborating the chief complaint is to take some negative history to rule out some other diseases. Say, let's suppose there is distension of the abdomen in this patient. We have elaborated a chief complaint in order to go in a line of chronic liver disease. Second, we have to take some negative history to rule out some other disease. Like if the patient is having distension of abdomen can also be possible in a patient of congestive heart failure. So we have to take the history of congestive heart failure, that this distension is not because of congestive heart failure. So we have to take the history that there is no history of orthopnea, PND, paroxysmal nocturnal dyspnea, or dyspnea on exertion. That is taking the negative history. We will discuss all the negative history in detail, but first you have to understand that while elaborating a chief complaint, we have to elaborate first in order to go in a line of diagnosis. Then we have to take some negative history to rule out some other differential diagnosis. And then third, we have to take the history of complication of the disease, the history of the complications of the disease. So if based on our elaboration, there is a provisional diagnosis of chronic liver disease, we should take some history of complications of chronic liver disease, like that of UGI bleed. So patient of UGI bleed will present to us with hematemesis and melena. So we have to take that history that there is no history of hematemesis or melena, or is there any history of hematemesis or melena. So the basic three rules in elaborating the history of present illness is, first we have to elaborate the chief complaint in order to go in a line of diagnosis. Second, we have to take some negative history to rule out some other differential diagnosis. And then third, we have to take some history of complications of the disease. So here you can see, while elaborating our chief complaint, that is the distension of the abdomen. So first we have to keep our mind open that this distension can be either because of fluid, either because of fats, it can be because of flatus, or the gaseous distension, it can be because of fetus in female patient, it can be because of full bladder, or it can be because of feces. So as we know that there is distension of abdomen for the 6-month duration. So it is a long history, that is the distension is gradual, or it is not occurring suddenly. If the distension was occurring suddenly within 1 to 2 days period, the differential diagnosis for this will change, as when there is sudden distension of abdomen, the causes of sudden distension are different than the causes of gradual distension. In chronic liver disease, it is usually a gradual and progressive distension of the abdomen. So we have to mention in history of present illness that my patient complains of gradual and progressive distension of the abdomen, or my patient was apparently normal 6 months ago, then he or she notices the gradual distension of abdomen which was progressive in nature over the 6-month period. And then we have to take the negative history that this distension was not associated with constipation. This distension was not associated with constipation or obstipation. Why we are taking the history of constipation and obstipation? To rule out intestinal obstruction. There might be sometimes obstruction present in the patient, and if there is obstruction, we know how the patient of obstruction present to us. The patient of obstruction will present to us with abdominal distension. There will be abdominal pain associated, and the patient will not pass any stool, and the patient will have recurrent vomitings. The patient will be severely dehydrated on examination, and the patient may sometimes have features of peritonitis if perforation has occurred because of obstruction. So, to differentiate that this distension is not because of obstruction, not because of feces accumulating in the abdomen which is causing the distension because of obstruction, we have to mention that my patient complains of gradual and progressive distension of abdomen for around 6-month duration. The distension was gradual and in progressive in nature. This distension was not associated with constipation or obstipation. By taking the history of constipation and obstipation, we are ruling out that this distension is not because of intestinal obstruction. That is, it is not because of flatus or it is not because of feces. Then we have to take that history that this distension is not because of full bladder. Sometimes the patient of full bladder, if the bladder is full, the patient is not able to pass any urine and there is urinary retention in the patient. So this patient will also have abdominal distension because of full bladder. When you see that abdomen is distended, especially the suprapubic region distension associated with full bladder and urinary retention. So this patient will complain of full bladder, patient will complain of pain in the abdomen, and this patient will complain of inability to pass urine or painful. When the patient try to pass urine, there is pain in the suprapubic region or there is dribbling of urine. So you have to take that history of there is no history of pain abdomen, there is no history of suprapubic pain or pain abdomen, there is no history of inability to pass urine. So to rule out full bladder. So we have discussed to rule out flatus and feces, we have to take the history of intestinal obstruction, that there is no history of constipation or obstipation. What is constipation? Constipation is there is reduced frequency and amount of stool. So the patient cannot pass stool, and if the patient cannot pass stool for longer duration, that is constipation. And what is obstipation? If the patient cannot pass stool as well as the patient cannot pass flatus, that is the gas, then it is known as obstipation. Both stool and flatus, that is known as obstipation. Only stool is known as constipation. So we have to mention that this distension is gradual and progressive for around 6 month duration, and it is not associated with either constipation or obstipation, nor it is associated with any pain in the abdomen or especially the suprapubic pain, nor it is associated with recurrent vomiting to rule out intestinal obstruction, nor it is associated with inability to pass urine, painful urination or dribbling of the urine to rule out full bladder. Then obviously in the female patient you can mention the history of last menstrual period to rule out any pregnancy, that is the fetus. So then what left is the fluid and the fat. Fat is obvious. For fat the patient may not present to us with abdominal distension, rather you can say that this distension is present for longer duration, it was more gradual and it is not associated with any symptoms. For the fat the patient generally does not present to us. So by this we can come to a conclusion by taking the negative history that this distension is probably because of fluid. So we have came to a conclusion based on our history that this distension is probably because of fluid by ruling out or by taking the negative history of the other F's, that is the fetus, the flatus, the feces and the full bladder. Now, when we focus on the fluid or when we came to a conclusion that this distension is because of fluid, now we have to think of the fluid. Now we have to think of the fluid. So the fluid in the peritoneal cavity, that is the ascites. So the ascites can be because of various pathological causes. So we are discussing about chronic liver disease. Ascites can be because of chronic liver disease. Why ascites occur in chronic liver disease patient is because of portal hypertension. Is mainly because of portal hypertension, and it is one of the signs of decompensation. So ascites or fluid in the peritoneal cavity can also occur in various other pathological causes, like that of if the patient is having TB peritonitis, if the patient is having TB of the peritoneum, then also ascites can occur. If the patient is having any malignancy, then also patient may have ascites. If the patient is having any malignancy of the liver, any malignancy of the gastrointestinal tract, any malignancy of the ovaries, the uterus, the pelvic organ, or malignancy of the peritoneum itself, the patient may have ascites, or if the patient is having any malnutrition, then also the patient may have ascites. If the patient is a case of congestive cardiac failure, that is the congestive heart failure, then also patient may have ascites. One way to differentiate that this ascites or this ascites is not because of congestive heart failure is to take the history of the swelling which occurred first. What I mean to say here is that if the patient is presenting to us with anasarca, so if the patient is presenting to us with anasarca, that is the generalized swelling of the body, there is facial puffiness, periorbital puffiness, there is also distension of the abdomen, and there is also bilateral lower limb swelling. So at first you may not be able to identify with which system is pathological. Then one important question you have to ask is that which system, or to differentiate between the system, that which body part started swelling first, whether it was the facial puffiness which occurred first, or whether it was the abdominal distension which occurred first, or whether it was the bilateral lower limb which was involved first. If the patient complained that it was the periorbital puffiness which occurred first, then it usually suggests the disease of the kidney like that of nephrotic and nephritic syndrome. Usually in a patient of chronic liver disease, because of portal hypertension, it is usually the abdominal distension which occurred first, and later on there is pedal edema or facial puffiness. And in patient of congestive heart failure or patient of congestive cardiac failure, because of increase in venous pressure, it is usually the swelling of the lower limb or the dependent part swelling. In patient of heart failure, there is swelling of the dependent part first, that is the bilateral lower limb in an ambulatory patient and the sacral regions in a bedridden patient. So to differentiate between the various systems, one way to identify is that to ask if the patient present to us with anasarca is to ask that it was the abdominal distension which occurred first, or it was the lower limb swelling which occurred first. If it is the lower limb swelling which occurred first, it mostly points towards the pathologies of the heart, that is the heart failure. And if the patient complained that it was the abdominal distension which occurred first, it mostly points towards the cirrhosis of the liver because of portal hypertension and there is ascites. So you can see in CHIP complaint we have written that there is distension of the abdomen first and later on there is swelling of the bilateral lower limb. So it was the distension of the abdomen which has occurred first, which again point to the chronic liver disease. There is distension of the abdomen because of portal hypertension. So which body part is involving first can suggest us the differential diagnosis. If it is the periorbital puffiness, it suggests us to the disease of the kidney like that of nephrotic and nephritic syndrome. If the first part is involved with the abdominal distension, it mostly points towards the disease of the gastrointestinal system, the liver, the GIT, the local pathologies of the gastrointestinal tract, the local peritonitis, and if it is the limbs or the lower leg, if it is the lower limb which starts swelling first, it mostly points towards the congestive heart failure because of increase in venous pressure. So now as we have elaborated our CHIP complaint in order to go in a line of diagnosis that this distension is mostly because of fluid, not because of fetus, not because of flatus, not because of feces, not because of full bladder, then concentrating on the fluid, the causes of accumulation of fluid in the peritoneal cavity, that is the ascites, can be varieties of causes, like that of chronic liver disease in patient of portal hypertension. It can be because of TB peritonitis, that is tuberculosis of the peritoneum. It can be because of malignancy, it can be because of malnutrition, it can be because of congestive heart failure. So now we have to differentiate between, or now we have to include the negative history to rule out other differential diagnoses like that of TB peritonitis, malignancy, malnutrition, and congestive heart failure. So we have to take the negative history that this distension is not because of TB peritonitis. So what history we will take to rule out TB peritonitis as a cause of abdominal distension, we will take the history of night sweats. We will take the history of night sweat, that there is no history of night sweat, there is no history of there is no history of evening rise or evening rise of temperature, there is no history of weight loss, there is no history of contact, there is no history of contact with TB patient. So we have to take the history of night sweat, evening rise of temperature, weight loss, contact with TB patient, and history of cough, hemoptysis, to rule out tuberculosis or disseminated tuberculosis in a patient of abdominal distension. So to rule out TB, we have to take the history of tuberculosis. To rule out malignancy, again, we can take the history of rule out malignancy, again, to take the history of weight loss. We can take the history of altered bowel habit, altered bowel habits. What is altered bowel habit? Altered bowel habit can be a complaint of both the TB of the gastrointestinal tract as well as malignancy. What is altered bowel habit? There will be a period of constipation followed by diarrhea, or the patient may have constipation, or the patient may have diarrhea, or there will be a period of constipation followed by diarrhea, constipation followed by diarrhea. This is known as altered bowel habit. So if the patient is having altered bowel habit along with abdominal distension, it again points us towards TB of the gastrointestinal tract or malignancy of the gastrointestinal tract. So we have to take the history of weight loss and altered bowel habit. To rule out congestive heart failure as a cause of abdominal distension, we have to take the history of orthopnea. What is orthopnea? Is that when a patient lies supine, there is shortness of breath, or shortness of breath in supine position is known as orthopnea. So if the patient is having orthopnea, it is along with abdominal distension, it usually suggests as a cause of congestive heart failure. And superadded to that, there may be lower limb swelling. And if you ask the patient carefully, the patient will complain that I had lower limb swelling first, then the abdominal distension occurred. Along with that, patient is having orthopnea. Along with that, patient is having PND, that is paroxysmal nocturnal dyspnea. So how the patient of paroxysmal nocturnal dyspnea will give us the history? The patient will say that I was sleeping comfortably at night, and suddenly at around 1 or 2 a.m., I suddenly wake up from sleep feeling short of breath. I was not able to breathe. I sat on the bed, keeping my feet down the bed, and then I had sweating, I had palpitation, and I was short of breath. I went to the window, I opened the window to get a fresh air. So this is the typical history of patient of paroxysmal nocturnal dyspnea, and it occurs in a patient of heart failure. The patient will be sleeping comfortably, and suddenly after 2 to 3 hours of sleep, the patient will suddenly wake up from sleep. Why the 2 to 3 hours of sleep is necessary to cause paroxysmal nocturnal dyspnea is because paroxysmal nocturnal dyspnea occurs because of reduce in sympathetic tone. So paroxysmal nocturnal dyspnea to occur, there must be reduced sympathetic tone. And to reduce the sympathetic tone, we should have around 3 to 4 hours of good sleep. When there is 3 to 4 hours of good sleep, usually during night, our sympathetic tone decreases. And when our sympathetic tone decreases, our heart rate decreases, our blood pressure decreases. And if the patient is a case of heart failure patient, and when the sympathetic tone decreases, the heart rate will decrease, the blood pressure will decrease, and because of decrease in heart rate, there will be reduced cardiac output. As the patient is already having reduced cardiac output and reduced stroke volume in a heart failure patient, superadded to that, during sleep, there is further more reduction in the cardiac output and stroke volume, and the heart will fail more. So there is the episode of paroxysmal nocturnal dyspnea because the heart is failing more during sleep. After 2 to 3 hours of peaceful sleep, there is activation of the sympathetic tone, which is causing the heart to fail more and more. That is the paroxysmal nocturnal dyspnea. Along with that, the patient may have this history of dyspnea on exertion. Dyspnea on exertion, that is when the patient is doing some exertion or activity, there is shortness of breath. So to rule out congestive heart failure as a cause of abdominal distension, we should take the history of orthopnea, PND, and dyspnea on exertion. So what makes the history more beautiful is the negative history. The examiner will understand, as well as it will help you differentiate between various pathologies at your clinics during your practice. Is that you have to take the negative history. You have to keep your mind open and broad, and you have to think about the many possibilities which can occur for a particular chief complaint, that is the distension of the abdomen. First, you have to elaborate the chief complaint in order to go in a line of diagnosis. Keeping your mind open, you have to think that this abdominal distension can be either because of fluid, can be because of fetus, flatus, fat, full bladder, and feces. And one by one, by taking the negative history, you have to rule out all these causes. And what left is the fluid. You have to concentrate on the fluid, that this fluid accumulation can be because of liver disease, because of portal hypertension, can be because of TB peritonitis or TB of the gastrointestinal tract, can be because of malignancy, can be because of malnutrition and heart failure. So you have to take the negative history of TB, that is the night sweat, evening rise of temperature, altered bowel habit, weight loss, contact with a TB patient, cough and hemoptysis. To rule out malignancy, you have to take the history of weight loss and altered bowel habit. To rule out congestive heart failure, you have to take the history of orthopnea, paroxysmal nocturnal dyspnea, and dyspnea on exertion. If the patient present to us with anasarca, one important question you have to ask to look for the system involvement is which body part started swelling first, whether it was the puffiness, whether it was the abdominal distension, or whether it was the bilateral lower limb swelling. So once you have elaborated the chief complaint, that is the distension of the abdomen and the swelling of the bilateral lower limb, then and you have taken the negative history to rule out other differential diagnosis, then you have to come and take the history of complication of the disease. So you have taken the negative history that it is not because of flatus, not because of feces, not because of full bladder. It is mostly because of the fluid present in the peritoneal cavity, that is the ascites. Now you have taken the history that this ascites is most likely because of chronic liver disease, as you have taken the negative history of peritonitis, malignancy, heart failure. Malnutrition can cause ascites, but usually there will be history of steatorrhea because of malabsorption syndromes. The patient may have steatorrhea, and most of the findings will be in general examination of malnutrition. So you have ruled out all these causes. Then what is left is the portal hypertension and the chronic liver disease. So your provisional diagnosis is chronic liver disease and portal hypertension up to this stage of history taking. Then you have to now take the history of complications of chronic liver disease, whether or not any complications of chronic liver disease is present. So what may be the complications of chronic liver disease? The upper gastrointestinal bleeding. There may be upper gastrointestinal bleeding because the esophageal variceal bleeding. So the patient may have upper gastrointestinal bleeding. As there is portal hypertension, there is decompensation. The veins in the esophagus dilate, which can rupture and can cause bleeding. That is the upper gastrointestinal bleeding. So when the patient have upper gastrointestinal bleeding, what chief complaint or what complaint the patient will have? The patient will have complaint of melena. The patient will have complaint of melena and hematemesis. Patient will have complaint of melena and hematemesis. What is melena? Melena is black color stool and hematemesis is blood in vomitus. So why there is black color stool? As there is rupture of the esophageal vein, this esophageal vein was dilated because of portal hypertension, and there is rupture of the esophageal vein, so there is blood in the stomach. This blood in the stomach get digested in presence of HCl, and which can cause coffee ground vomitus, that is the hematemesis. It can pass through the gastrointestinal tract from small intestine and large intestine. It may get digested and can change its color into black, that is the melena or the black stool. So the vomitus is hematemesis, or blood in vomitus is hematemesis, and coughing out blood is hemoptysis. We have seen how to differentiate hematemesis and hemoptysis in our respiratory system module. You can watch there. So the patient of upper GI bleed can present to us with melena and hematemesis. And second important point is that, or the second complication of chronic liver disease can be hepatic encephalopathy. So what is hepatic encephalopathy? If there is, so in patient of liver disease, there can be hepatic encephalopathy. What is hepatic encephalopathy? Because of excess amount of ammonia. Because of excess amount of ammonia, as we know that one of the function of the liver is to convert ammonia into urea via the urea cycle. One of the function of the liver is to convert ammonia into urea via the urea cycle, and this urea is excreted via the kidneys. This urea is excreted via the kidneys. So if liver is damaged, this ammonia is not converted into urea, and there is excess amount of ammonia in the blood, and this ammonia can reach the brain, and when there is excess amount of ammonia reaching the brain, it can disrupt the brain function, causing hepatic encephalopathy, that is the metabolic encephalopathy. So how the patient of hepatic encephalopathy will present to us, or what will be the history which will help us identify whether or not the patient is having hepatic encephalopathy. Hepatic encephalopathy is a serious condition of chronic liver disease, and many of the time it can lead to death of the patient. So the early identification of hepatic encephalopathy is important. So what important history the patient will give in hepatic encephalopathy, or what history the attendant will give? The attendant will give the history of altered sleep pattern. Altered sleep pattern. What I mean by altered sleep pattern is that the attendant or the patient's relative will complain that my patient sleeps during daytime but does not sleep during nighttime. Nighttime he is very active, talking to everyone, but during daytime he is sleeping. That is, the sleep pattern is altered, the sleep wake cycle is altered, and this one clinical feature is a hint to an early identification of hepatic encephalopathy. So you have to mention in a history of complication that whether or not these symptoms are present. If present, you have to mention it. If not present, then also you have to mention that there is no history of melena, there is no history of hematemesis, there is no history of altered sleep pattern. So the one of the complication can be UGI bleed, one can be hepatic encephalopathy. The patient can sometimes have hepatorenal syndrome and hepatopulmonary syndrome. Hepatorenal and hepatopulmonary syndrome. The patient of hepatorenal syndrome, which the mechanism of which we will discuss later, that because of liver pathology, the kidney is failing. If because of cirrhosis of the liver, the kidney is failing, this condition is known as hepatorenal syndrome. That means the serum creatinine levels are rising because of chronic liver disease. So the patient may sometimes have history of reduced urine output. We have seen that patient of full bladder can also have reduced urine output, but that reduced urine output will be associated with symptoms of retention of the urine, like that of pain in suprapubic pain, or dribbling of the urine, or pain while urinating, or severe pain while attempting to urinate. That is the urinary retention. And reduced urine output, there is no urine formation in a patient of hepatorenal syndrome. So sometimes the patient of hepatorenal syndrome can present to us with reduced urine output. A patient of hepatopulmonary syndrome may present to us with platypnea. What is platypnea? Platypnea is shortness of breath in sitting down position. So you may be thinking why there is shortness of breath in sitting down position. When the patient is sleeping or in supine position, there is no shortness of breath. But when the patient sits up, there is shortness of breath because of hepatopulmonary syndrome. What is the mechanism of platypnea or shortness of breath in sitting down position? Shortness of breath in sitting down position is known as platypnea. It occurs in hepatopulmonary syndrome. What is the mechanism of platypnea in hepatopulmonary syndrome? It is actually the arteriovenous shunting of the blood in the lower part of the lung or in the bases of the lung. Because of chronic liver disease, there is increased production of TNF alpha and vascular endothelial growth factor, both of which causes neovascularization or new blood vessel formation in the bases of both the lung, both the lung. So there is neovascularization in the base of the lung or the lower parts of the lung. There is neovascularization. When there is neovascularization, there is formation of arteriovenous fistula. There is no capillary. There is atrial side, there is venous side, but there is no capillary. So if there is no capillary, gaseous exchange will not occur, and this neovascularization is abnormal because there is no capillary. The oxygen coming in the lungs will not be exchanged with this blood as because there is no capillary because of neovascularization. So when the patient sits down, because of gravity, more of the blood will pass through this lower part of the lung, and it will be an unoxygenated blood. Without oxygenation, the blood will reach or cross the lung and reach the left side of the heart. So there will be no oxygenation in sitting down position, as because in sitting down position most of the blood will pass through the base of the heart because of gravity. So the patient will have platypnea, that is shortness of breath in lying down, in sitting up position, and the patient will be comfortable in lying down position, as because in lying down position blood will pass from all part of the lung, and the above and middle part of the lung does not have neovascularization or does not have arteriovenous shunting. So this is the mechanism of hepatopulmonary syndrome. So you have to mention that the patient does not have shortness of breath in sitting down position. That means you are ruling out one of the complication of the disease or complication of the chronic liver disease, that is the hepatopulmonary syndrome. The patient may have spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. What is spontaneous bacterial peritonitis? As because there is accumulation of fluid in the peritoneal cavity, that is the ascites. So when we see, let's suppose this is the abdomen of the patient, and here are your gut, the transverse section of your gut, and you know that your gastrointestinal tract, or here this is the lumen of your gastrointestinal tract, and the lumen of your gastrointestinal tract normally contain many microbial flora, mainly the E. coli. The lumen of the intestine contain microbial flora, that is the E. coli, and here is the fluid present, the peritoneal fluid or the ascitic fluid present in a patient of chronic liver disease. So in a patient of chronic liver disease having ascites, there can be transmural migration of this gut flora. This gut flora can transverse the gut wall and can reach the ascitic fluid, as because the ascitic fluid is a good culture media. So the E. coli present in the lumen of the intestine can migrate through the wall of the gastrointestinal tract. It will not perforate the wall of the gastrointestinal tract, but it will migrate transmurally. So this is known as transmural migration of the microbial flora, mainly the E. coli, to reach the peritoneal space or to reach the ascitic fluid, which is a good culture media. So this process is occurring without perforating the gastrointestinal tract. So this process is known as spontaneous bacterial peritonitis. Why it is called spontaneous? Because it is not perforating the GIT wall and it is migrating transmurally. So it is known as spontaneous bacterial peritonitis. Bacterial peritonitis can occur after intestinal perforation if the patient is having intestinal obstruction and that obstruction had led to perforation. And because of perforation, now the bacteria of the lumen has reached the peritoneal cavity and multiplying there and causing peritonitis. That will be simple bacterial peritonitis because of perforation. But when we are using the term spontaneous bacterial peritonitis, it occurs specifically in a patient of ascites. And when there is ascites is a good culture media which will cause transmural migration of the bacterial flora, mainly the E. coli, from the lumen to the ascitic fluid, which is a good culture media to cause peritonitis. As there is no perforation of the GIT wall, it is known as spontaneous bacterial peritonitis. So, spontaneous bacterial peritonitis can occur in a patient of chronic liver disease. And how the patient of SBP will present to us? The patient of SBP will have fever. The patient of SBP will have fever. The patient of SBP can have pain abdomen along with fever, and there may be history of sudden distension of the abdomen. The patient was having slight distension of the abdomen for around 4 to 5 months, but within 2 to 3 days that distension has increased rapidly within 2 to 3 days. So sudden increase in girth of the abdomen or sudden distension of the abdomen from a mild distension, there is sudden increase in distension of the abdomen because of multiplying bacteria in the ascitic fluid and causing more permeability of the peritoneal vessel, leading to more accumulation of the ascitic fluid and sudden increase in the ascitic fluid and sudden increase in the girth of the abdomen or sudden increase in size of the abdomen can be caused by spontaneous bacterial peritonitis. So if the patient is giving history of fever along with pain abdomen and sudden increase in size of the abdomen, then we can suspect the condition, that is the spontaneous bacterial peritonitis, only in a patient of established case of chronic liver disease or suspected case of chronic liver disease with ascites. So for SBP to occur, ascites should be present. So for SBP to occur, ascites should be present. So SBP can occur in case of ascites because of either chronic liver disease or ascites because of nephrotic syndrome. Sometimes SBP can occur in a patient of nephrotic syndrome. So not all conditions can lead to SBP. The majority of the conditions are chronic liver disease ascites and nephrotic syndrome ascites, which can lead to spontaneous bacterial peritonitis. So this is the way how we take the history of chronic liver disease. We have discussed the chief complaint and the history of present illness till now. So at first you have to elaborate the chief complaint in order to go in a line of diagnosis, that you have to differentiate or take the negative history of these 5F or the 6Fs. And then after elaborating your chief complaint, we have to take some negative history. To rule out some other disease. What may be the other causes of this ascites? So to rule out TB peritonitis, to rule out malignancy, to rule out congestive heart failure, we have to take some negative history. Then we are coming to a conclusion that this is ascites mostly because of portal hypertension due to chronic liver disease. Then we are taking the history of the complication of the chronic liver disease, that can be UGI bleed, hepatic encephalopathy, that can be hepatorenal, hepatopulmonary syndrome, or that can be spontaneous bacterial peritonitis. So at first you have to keep your mind open, or you have to think broad. Your diagnosis should be a broader diagnosis. Then you have to narrow down one by one all the possible causes. There was distension of abdomen. First you have to think why there was distension of abdomen. Then you came to know that the distension of abdomen was because of ascites. Then you have to think what might be the cause of this ascites, whether it is TB peritonitis, whether it is CLD, whether it is malignancy, whether it is congestive heart failure which is causing ascites. You took the negative history and you ruled out the other cause, and you came that this ascites is mostly because of chronic liver disease. Then you have to go one step forward to take the complication of, or the history of the complication of the chronic liver disease, and you have to say that this patient, whether or not he or she have history of melena, history of hematemesis, history of altered sleep pattern, history of reduced urine output, history of shortness of breath in sitting down position, that is platypnea, history of fever, pain abdomen, and sudden increase in the size of the abdomen. Sometimes the patient of chronic liver disease, because of splenomegaly, there can be features of hypersplenism. Not all splenomegaly can cause hypersplenism, and not all hypersplenic patients have splenomegaly. So Sometimes because of splenomegaly, the patient may have hyperinsulinism. What is hyperinsulinism? There is increased function of the spleen. Increased function of the spleen is to destroy all the cell line. That is the WBC, the platelet, the RBC. We know that our spleen is the graveyard of the RBC, but it's graveyard, or it can sometimes destroy WBC and platelet also. So if there is enlargement of the spleen, or sometimes without enlargement of the spleen, this hypersplenism can occur, in which the destruction of the RBC, the WBC, the platelet can occur. So the patient will have reduced RBC, that is anemia, reduced WBC, that is the leukopenia. The patient may have reduced platelet, that is the thrombocytopenia. And because of reduced RBC, there is anemia, and the patient may have symptoms of anemia, the fatigue, the tiredness, the lethargy. The patient may have reduced WBC, which can make the patient susceptible to many infections, the respiratory tract infection, the urinary tract infection. The patient can have any type of infection because of reduced WBC. Because of reduced platelet, the patient may have coagulation defect. The patient may present to us with petechia, the purpura, the bleeding. So the patient, because of thrombocytopenia, usually there is mucosal bleed, and because of coagulation factor defect, it is usually the joint bleed. So the patient of CLD may have either coagulopathy, coagulation factor defect, the patient may have joint bleed. The patient may have, because of reduced platelet, the patient may have bleeding from the mucosa, the nasal mucosa, the oral mucosa, the GI mucosa. The patient may have hematuria also sometimes. So there is everywhere bleeding in a patient of chronic liver disease, either because of platelet, reduce in platelet, that is thrombocytopenia because of hypersplenism, or because of coagulation factor defect. Because of liver disease, the patient may have joint bleed. So these all are the complication of chronic liver disease. So we have seen how to approach a patient of distension of the abdomen in a case of chronic liver disease. You have to mention all these points in a sequence wise. First, you have to take the history to elaborate the chief complaint, then you have to take the negative history, then you have to take the history of complication. In both in exam as well as clinical practice, you will not miss any other possible cause of abdominal distension if you are not directed to a particular disease. So one important point, you should not be never be directed to a particular disease. If you are presenting a history in a directed way that this patient is a case of chronic liver disease, you are not mentioning any negative history from a sequence manner, then it will be a not good help both in exam as well as your clinical practice. So you have to think in a clinical way, and you have to approach in a clinical way to do good in exam as well as your clinical practice. So we have discussed up to history of present illness. In next lecture, we will discuss what are the important past history, family history, personal history, drug history, and other relevant history in a patient of chronic liver disease.